Thank you. It's very good to be here. Can you all hear me okay? I see you've all chosen to sit above the tree line. I guess that's the safest place down here as well as where I'm from. I gave David the title originally, and it's on the posters, The Ethics of what I say, Ethics of Innovation, Surgery and Medical Devices. And this title that's up there is the title that David originally proposed as we were discussing this topic. As I was working through my slides, I realized I was on slide 49 or so, and I was about a third of the way or halfway through my talk as I was running through a whole range of examples, and I realized that was not particularly feasible, although as my wife will tell you, and as you probably can hear already, I'm talking very fast, and I can probably fit all that material in. But mercifully, I've cut it down, and I'm just going to work with one example. What I want to do today is, and I've got an outline, I want to contrast what I'm going to call a conventional view of innovation in medicine. I'm going to spend just a little time sort of staking out why I take that to be the conventional view, and we might have some discussion, I hope certainly, about that after this talk, because I understand we do have some time afterwards. And what I'm going to call an alternative view, or sometimes in the talk I'm going to refer to it as a dynamic or developmental view of innovation in medicine. What I want to do is lay out assumptions of the conventional view. I want to use the historical example of coronary artery bypass graft surgery to question the adequacy of the conventional model of innovation. And then I want to conclude by drawing some implication for an ethics of innovation. I should warn you, however, that what I'm going to say about the ethics of innovation is going to be actually very sketchy, because I'm working here at a fairly high level, and partly that is the case because I take the view that so much of what we do in ethics is structured by and is in some sense predetermined by, in effect, tacit knowledge or background assumptions. And if that's the case, then we're in an era where the assumption that patients have certain rights is accepted. I'm old enough to remember when talking to physicians about patients' rights, brought a very perplexed look in my first few years of teaching at Southern Illinois University Medical School in the 70s. Doctors didn't know what I was talking about, and they certainly didn't know or greatly appreciate, the right of patients to refuse life-sustaining treatment and have conversations and so on. So now we're in a context post the IRB regulations 1974 where we have a certain assumption about what should be the case. I'm going to lay some of that out and suggest that that may not be the best model for thinking about the ethics of innovation, and so that's why I'm taking this very broad view. Okay, let me sketch out what I call this conventional view. First of all, it assumes, I think, a stable background of knowledge and set of practices. That is the case. Innovation comes into medicine over and against what are accepted practices. I mean, you all know about evidence-based medicine. I mean, doctors don't practice on the basis of what they don't know, but on the basis of what they know. Now, we all know, you all know, that that's certainly not exactly the case, that it's much more complicated than that, and there's various types and degrees of evidence that function within the practice of medicine and surgery. But nonetheless, I think when people think about innovation in medicine and how we should handle it, the assumption is that it's something that is new in the sense that it is untried and deserves some special treatment because things are just fine as they are. And because of this, then innovation deviates from accepted practice standards, and that raises a host of questions about how we should handle it. So the standard view, in my opinion, is that innovative treatments are suspect, and the subjects, or the individuals, I should say, receiving those treatments should do so under the protection of formal research protocols. And that's basically the standard view that I think dominates in the literature and certainly infects most bioethics discussions of innovation. Is that better? Okay, I apologize for that. And again, some of the assumptions that underlie this view is that evidence supports current practices, and I mean evidence in a fairly acceptable or robust way. And so most practices are well-grounded, and in fact, the burden of proof should always fall on the side of the innovator rather than on the side of carrying out accepted practices. And that the current practices and standards enjoy, as it were, and this is a separate point, even though it looks like the same, a high degree of confidence. So whether or not there is epistemological and scientific evidence supporting a practice, it's the belief structure within medicine that says what we do is done for the best interest of our patients, and what we do is effective and ought to be done, that frames, I think, this conventional view. And so change is not highly, or deviation from practice is not highly valued, and innovation or any, what I'm going to call deviant procedures, are best handled within the domain of research. That's another way to think about it. So if you just do a Venn diagram of this, you see practice sits in this very odd position right in the middle between research and practice, and the conventional view is to take it and, as it were, try to pull it with, recognize that it's in practice because what you're doing in an innovative procedure with a medical device is you're applying it to patients, but to push it onto the other side and to make it conceptualized under the rubric of research with human subjects. Now, let me give you one example. There are many examples that sort of underscore this view, but maybe the canonical text is from the Belmont report that, as most of you know, but some may not know, was published after the work of the President's Commission. The National Commission. It was a National Commission that actually wrote a number of reports in the early 70s and was responsible for creating the regulatory framework that exists for the protection of human subjects. And after virtually all of the work was done, the Belmont report was put together as a way by which those commissioners reflected on what they did, and they articulated after the fact, not before the fact, certain principles. And we can have a discussion afterwards about what's the function of principles in bioethics and in the work of this commission. But nonetheless, this document is a seminal document in bioethics. And I just want to call attention to a couple of passages from it. The report defines practice as interventions that are designed solely to enhance the well-being of an individual patient or client and that have a reasonable expectation of success. Research, in contrast, and this is really understood by the commissioners as a contrasting relationship. It's an activity designed to test an hypothesis, permit conclusions to be drawn, and thereby to develop or contribute to generalizable knowledge. Now, I don't want to go into their discussion of what happens when research is combined with practice, because they certainly recognize that. I want to just draw your attention to this passage, which really I think is the seminal one. This is their fundamental recommendation. They say the fact that a procedure is experimental, and they use that language, but for my purposes, it's an innovative procedure. They recognize these occur in medicine all of the time. You have drugs that are approved and vetted through the FDA for certain approved indications. You're a physician, you use them for another indication. That's a kind of experiment. It's a deviation because there may not be the scientific basis. After you and your colleagues do that over many years and there's a reported experience of that, that certainly constitutes an evidentiary basis for the use of that alternate use of the medication. But nonetheless, it is, and I think should be thought about as an experiment in the sense of something innovative. Okay, so the fact that a procedure is experimental in the sense of new, untested, or different does not automatically place it in the category of research. They recognize that. But they do go on to say that radically new procedures of this description, and this is the important part because this is the part that comes next, which is cited by virtually all commentators, should, however, be made an object of formal research at an early stage, and I add the emphasis, in order to determine whether they are safe and effective. And so, on this conventional view, innovation is experimental, and because of that, it's suspect. And it's only scientific research that can provide, as it were, the mechanisms to justify experimentation. And we have, as you well know, this ideal of the randomized control trial, which is of interest here because when you think about what a rigorous randomized controlled trial does is, for you as a practitioner who enters a subject or patient into this trial, you, as it were, suspend your clinical judgment because you're now guided by protocol. And that's rather interesting. Now you and all of your training and your clinical experience and any other practice standards are held in abeyance. We know that that poses all kind of interesting ethical questions, but the norms of the clinical trial is actually designed to suspend that clinical judgment, that kind of variation that in fact we think as patients, and I think many within the field of medicine, think is quite appropriate in clinical practice. So to be ethical, research with human subjects requires IRB formal review and approval. And that review is important because it requires, among other things, a formal written in advance protocol. It requires not just review and approval, but a prospective review and approval. And you then have to conduct this study according to research standards, which again, as I said, requires adherence to the protocol and restricts the ability, as it were, unless you drop the patient from the study. And there are all kinds of incentives for you not to do so. Among others are economic incentives, because we fund these through federal and other mechanisms, and so losing patients or subjects in a study is not a good thing for you as a PI. And so within this context, I want to argue that that model really flies in the face of what I would argue is another way of thinking about innovation. That is not innovation that sits in, if I can point it, between research and practice as in the original Venn diagram, but is really a separate domain of activity. And some of it occurs in research, because if you take a perspective of philosophy of science, you realize that much attention is paid to hypothesis, a justification, and the construction of hypotheses and research protocols, but nonetheless, where did hypothesis generation come from? That's not something that's done in that sense always scientifically. Scientists looking at the same data, working in the same field, will come up with alternative hypotheses for the next legitimate research approach. That's something that I think has to be understood as something rather different than formal research in the more rigorous fashion. And I think innovation is a way to think about it. Experimentation is the other way to talk about it. And if you look at the literature, you'll find that many commentators, particularly in medicine, from around the late 60s and earlier through the 50s, who commented on this domain, really talked about experimentation. They didn't mean experimentation in the sense of just the conduct of a formal research study. They meant the conduct maybe of medicine under circumstances of uncertainty, where in fact the administration of a medication or of a procedure or a diagnosis really was laced with a great deal of uncertainty and often brought you more information and data than you need, and part of your job was a judgmental process of, as it were, filtering out the noise from the information. And part of what's happening now for some of you here, I see some of you look like you're medical students, part of what's happening for you in your training is to help shape your judgments so that you have, as it were, better filters to filter out extraneous information than lay people or others coming into medicine in order to form the more refined judgments that skilled practitioners and clinicians provide. Okay, let me talk now for a few minutes about what I call this dynamic view of innovation. I call it dynamic for the simple reason that I see innovation as functioning not over against, typically that is, not over against fields where everything's fine, thank you, where everything is functioning in an effective way, where there are no problems except perhaps way at the edges, but where there are genuine clinical dilemmas and problems of management. And so innovation comes in as a response in fields that, if you look at closely, even those for which there's settled opinion, there is, as it were, doubts, uncertainty, disagreements. Now, you might need to push deeply into the field, and only specialists or subspecialists appreciate that. many commentators look at that and say, if you start to talk about that, you want to introduce an element of skepticism about the legitimacy of medicine or the legitimacy of medicine as a science. And I radically reject that kind of line of criticism. My approach is to say we need to sort of accurately, phenomenologically, capture what the practice of medicine is from an epistemological point of view and to understand how complex and nuanced it is. It's just what some philosophers of science have done looking at science. Polanyi, for example, in thinking about science, talked about tacit knowledge, about how so much of scientific development and discovery operates from this tacit basis. And in fact, a lot of what we do functions in that way. And part of what I'm asking us to do is to thematize this tacit dimension. Okay, when I talk about the dynamic view of innovation, then I'm talking about those elements that we might call imaginative creative modifications or even the invention of procedures or approaches to address clinical problems or inadequacy in patient care. Not only are they there in the practice in this view, but they're valued. We look at them and say, that's a good thing. You're problem solving, you're being creative. Now again, when you're a medical student and you're being creative, your mentors are going to say, learn the rules first, learn the standard practice. But the skilled physician, if you talk to subspecialists communicating, as I had the privilege when I worked for 9 years at the Cleveland Clinic, and you listen to these people, man, they're talking at a level of disagreement and complexity. I mean, surgeons approaching, I was on the Advanced Heart Therapeutics Committee, which basically was the heart transplant committee, but it encompassed all of the modalities of advanced congestive heart failure therapies that were developed and administered at the clinic. So we talked about the whole range of these. And if I got to the meeting early, I'd see some of the surgeons, they'd be talking about the case that they had or they were prepping for, and what approach are you going to use? Oh, what about, have you thought about, why don't you? Discussions. Certainly wasn't the case that they were following a rule book, that they knew exactly what to do, that it was a settled opinion. There was judgment involved. That's highly interesting, and it's not problematic. I don't think you could look at the Cleveland Clinic's evidentiary-based and results and say, well, they're just sort of messing around. They don't know what they're doing. The results are superb. It's because that's essential to the most advanced and best kind of practices. And I want to say that that's the feature that this view tends to value. And so the focus in this view is what might be rather than what current practice supports. Rather than saying, well, we have only the following drug as a drug that's appropriate for your indication. When you're a patient, I mean, a patient wants to hear the doctor say, gee, this is what, I normally would prescribe, but since you not reacted appropriately to it, or you had side effect problems, or you can't tolerate it particularly well, maybe we should think about a different approach. That's what you want from a physician, because he's trying to tailor treatment to your unique situation. I would argue it occurs routinely in medicine. And we tend to underscore it when we think about innovations, because we tend to pull those out and think about those as foreign intrusions in the practice of medicine that need to be pushed across that divide so that we can actually protect people who are no longer regarded as patients but are thought about as subjects. And that transition from thinking about an individual who's being treated as a patient to a subject, I think, certainly has advantages, but it also has disadvantages, and I think we need to think about those disadvantages. And so another element of this dynamic view is that there's some degree of discomfort with a status quo or current protocol standards or procedures. And in some instances, in the example I'm going to work with here, coronary artery bypass graft surgery, one can say that innovation is sometimes driven by exigency and, that should be an expediency. I repeated myself. Expediency in patient care. I mean, that is the case that you don't have much choice as a surgeon or as a caregiver. What you have to offer is inadequate, you know it, and are you going to settle for that? Now the question comes up, under what context should you then extend the practice, and how do we regulate that? I want to suggest that we shouldn't say from the start that's a worrisome activity and we should only deal with it as research. And I'll give you some reasons why that's the case. Let me talk now about, and if somebody could grab some water, I'd really appreciate it. I've been struggling with some allergy problems, and, oh, yeah. Oh, right on the floor. It's on the floor.
Okay.
Thank you. I picked coronary artery bypass graft surgery for a number of reasons that I think are salient. First, most of the developments in the development of that surgical technique preceded 1974. That is when the, thank you, no, plenty. When the Code of Federal Regulations, I have 45 CFR 46, those of you that don't know, that's the place within the Code of Federal Regulations where the regulations are found for the protection of subjects of research. It preceded those. It preceded the creation of IRBs and certainly the Belmont report that I mentioned earlier. And I like that as an example because if you use more contemporary examples, you end up having to view them, most people, through the current filters. And I end up getting people asking me, yeah, but what was the research protocol? What was, and I want to belay that for a moment, okay? What I think is a remarkable feature of coronary artery bypass graft surgery is that when you look at its development, you see that there are multifactorial vectors of innovation. It wasn't a single just procedure, but it occupied or functioned within a whole framework of innovations in a field that could not be characterized as I characterized the conventional view of stability. That is the case. There was standard treatment. It was accepted. It was non-problematic. It worked. There was evidence that supported it. And basically, we were fine just practicing surgery and cardiology on that basis. Coronary artery disease, myocardial infarction was a disaster area in the 50s and 60s. And dramatic changes were necessary because treatments were grossly inadequate. And if you read the historical evidence, the current literature, you see that expressed in there. Even in medical and surgical publications, you find paragraphs where surgeons are going off on a tangent talking about the dilemma of being a surgeon and having to sort of do a patch graft technique to resect the damaged portion of the myocardium and know that that was not going to benefit the patient and that the patient might not survive the surgery, and you certainly was not going to restore vascularization to the heart, and even if the patient survived, there was going to be diminished cardiac function, and there were worries about that. So I think if you think about that, it really shapes how you react to innovation. So what were some of these innovations? Well, coronary angiography, which developed out of the visualization of the coronary arteries, or was the visualization of coronary arteries. Anesthesia, heart-lung bypass machines were created. There was improvements made in infection control, particularly sternal wound control and infection control. Surgical techniques like heart wall reconstruction and vascular grafting, and then the whole business of post-operative ICU care. None of those were inessential to develop, in my judgment, what came out as a coronary artery bypass graft surgery. So what I want to summarize by saying is that bypass graft surgery occurred against a background practice and a state of knowledge that was fluid. It wasn't stable. So the conventional view got it wrong, at least here. So even if you could say, well, the rest of medicine during this time was highly stable, it is, and it may well be the case, that there are fields within medicine that are highly unstable, and they're best characterized as fluid or best gel states. So the notion that you could rely on standard care and any innovation that comes in ought to be treated under research protocol may be appropriate for some well-established and settled fields. I would argue maybe not in others, and I would suggest to you that the state of stability of the field is a historical example. It's an artifact. And as you move forward, fields that looked like standard practice is accepted drastically over decades or over a practice lifetime become unstable because new knowledge emerges. And that's a fact that we need to pay attention to by looking at the history of medicine. It's also the case that the scientific knowledge base was simply inadequate, and it's best described as emergent. And in fact, if you look at the experience, it was highly local. Coronary angiography was developed in 1962, developed out of the earlier use of the imaging of the coronary vessels that developed in 1958, and it was an accident. I mean, everybody thought that if you injected dye into the heart, you would stop the heart. And so it was an accident. Dye was injected. The 16 millimeter cameras, because they used 16 millimeter film. Think how primitive this was and the kind of technology that was used. Very few institutions had the capacity to use this technology. The Cleveland Clinic, among others, was one of the few that did that. And so it's a case that the technology created the possibility for a new way of looking at things. And what I suggest is that these innovations were driven by the inadequacies of the current management of coronary artery disease and myocardial infarction, as I said. Now, let me just give you an example here. No, I've already covered that. Never mind. If we look at this example again, I know I'm going in an incredibly sketchy fashion. I'll fill in details if you want me to after in the question and answer period, because I don't want to delay a lot of discussion of this particular example. But one thing you can summarize is that it wasn't protocol driven. That is, there wasn't an IRB, there wasn't a formal protocol. The surgeons weren't restricted to a set protocol and then have to do a series of patients through that, evaluate the results, and then expand the procedure. If you look at what happened was the initial vessels that were done were with very localized infarcts, intentionally done. They were done by Favallaro after Mason Soms at the Cleveland Clinic said to him, you've got to only do those with where there's a patent, a collateral flow, because if the vessel occludes that you're going to graft, you may cause a further infarct and problems. And so there was efforts made to minimize. So this patient selection was only gradually in 68, I guess it was. Let me check my dates here. I think I have that on a later slide. When they published this data, 171 results, if you look at the data, and I have, you see that the data initially were very localized blockages with very small domains of damage to much more larger ones as the skill level increased. The worry was, of course, that the more surgery you did, the more risk that the patient was, even if the surgery was a success, that the patient would die postoperatively. So the interaction of postoperative care and the surgical management and the care in the operating room was critical to the development of this procedure. Now, I'm mentioning some more examples of the dynamic state of the field. There was a high mortality from myocardial infarction during this period of time. Everyone admitted to the inadequacy of standard treatments. If you look at the understanding of the disease processes and mechanisms and look at the scientific literature, you'll see there was a great deal of discord. For example, it was proposed early on that you would use veins to replace the artery. The saphenous vein, as you probably know, is used by Favallaro. It was reversed so that the it would not clamp down. But there was no belief that those veins, one, could withstand pressure. Now, there was animal work on that, but still surgeons believed that they weren't going to take it into the OR. Now, what justified that leap of faith? I mean, we don't know. Favallaro has written rather extensively on this. He said he gradually became convinced after studying 100 and some of these sign cinematic catheterizations, where he saw that there were two types of occlusions, and that if you then restored flow in the one type of occlusion, that you might then restore the damaged myocardium and prevent permanent damage. And so there was a selection process made based on that. If you look at the evidence throughout those years, you'll see that the understandings of the disease mechanisms for the management of myocardial infarction also changed from 61 through 68, or a little later than that. Now, how else can we view CABG? Well, we can see innovation as a natural adaptation to dynamic clinical circumstances. I mean, I think this happens in normal patient care when, in fact, you have a bunch of patients, they all have the same diagnosis, but they all look a little different and they have different symptoms, and so they all come away with a different set of prescriptions. Just think about, I'm struggling with some kind of postnasal drip now. Do I have an allergy problem or whatever? I mean, that's a symptom that typically is going to be managed by a physician. Someone else comes in with chest congestion. They may be handled in a slightly different way. We tend to minimize and forget those variations, but those variations, I think, reflect the kind of exercise of clinical judgment as managing medical information and knowledge based on immediate patient need. When the treatment options are unsatisfactory, as they were in the case of myocardial infarction in the 50s and 60s, then you have even greater urgency towards innovation. And I think you could make the case that innovation was driven by exigencies and expediencies that were really associated by surgeons treating patients brought in for MI. There was widespread sharing of information from one center to another, not just surgeons within centers, talking about the cases that they had, what procedures they did, what were the outcomes. That was rather remarkable because, I mean, we have this view that, what you ought to do is freeze a study, set the parameters, and run it through, and don't report anything, God forbid, until all the results are in, because when you have, robust statistical power, you can report results. They didn't do that, and I think it proved far better for the development of bypass graft surgery. And in this instance, unlike the model that I suggested earlier, where in fact we push innovation on the side of research, and then we tend to say, and you heard this language constantly, medicine moves, developments move from the bench to the bedside. But it's the case that many of the researchers at the bench are also practicing and drive their clinical decision-making or their scientific hypothesis generation from actual clinical problems. We've tended to underestimate and attend, I think, the movement from the bed to the bedside. And that's a problem in the way then we think about innovation. Okay, so what can we say about the ethics of CABG? Now, having mentioned this, well, I'm going to mention just two sort of cardinal worries that we have now. They're built into our regulatory mechanism, and any bioethicist worth his salt and any physician or clinical researcher certainly is going to worry about these. Well, what about informed consent? Well, one thing you could say is, this is the easy answer, just the main developments of the procedure occurred before IRB requirements and research regulations, so they didn't have to do it. Well, that's a pretty weak and dumb answer, but I'll mention it anyway. But I think the other thing we need to recognize is it was prior to the wide-scale acceptance of informed consent, not just in research context, but in clinical practice at all. I mean, informed consent gradually emerged in the 60s and 70s and became part of what we taught medical students really in the 70s and 80s. And so medical students or doctors weren't trained that informed consent was part of what you did and had to do as a part of your ordinary course of practicing medicine. So we tend to need to remember that worry about informed consent is a lens that we have now, but historically we're looking back at a time when that wasn't so prominent. Well, the other thing we need to recognize is that many of the patients, at least the patients that were suffering from MI, many of them were unlikely to be able to give informed consent anyway. So we're going to have surrogate consent situations. And I don't know what your view is, but certainly it's anathema to many of my colleagues in bioethics. But I look at informed consent and say, you know, it's an ideal, and the practice is really considerably variable. And the reality is much more complex than, as it were, the standard textbooks will tell us about informed consent. And the degree to which we have reliance on the patient's comprehension and understanding of information and then consent to a procedure, I think is marginal at best. I mean, the model tends to assume that all you do is make decisions based on knowledge, as if your own emotional state, your own, as it were, disposition towards the need for care or the desire not to be treated, to be out of this institution, the hospital, influences your medical decision making. Those are factors that now medical decision literature is starting to pay attention to. But the model of informed consent is built on this philosophical model of the rational decision maker, and the rational decision maker maximizes opportunity based on information. You know, well, the reality is most of us don't, and too much information becomes, as it were, noise. It's like the family in the ICU. It's a kind of paradigm family, in my experience, who comes in and says, how many mics of dobutamine is my brother on, or is my family member on? Man, they know that. They got a graph of that. You ask them, as a clinical ethicist, bioethicist, non-physician, say to them, do you know what that means? Why? Typically what they say to me. And I say, because I've been hanging around medicine for, then when I worked at the Cleveland Clinic for 30 years. I've been doing clinical ethics consultations for 20-some years, and I don't know what that really means. But they presume to know. We feed information that feeds an intellectual defense mechanism that fails to get patients to think about what's their problem often. And so that's another side of informed consent that's problematic. So I want to mention that as a background when I talk about informed consent. I'm not so impressed that we got informed consent. And when you hang around research centers and you find that you got research nurses who will look at you and say, I got to get moving, George, because I've got 3 more patients to consent. Something I do to patients, I consent them. Okay? You can see the model is a bit distorted, and it may not involve that kind of mutual understanding, nor a level in which patient really has their compromised autonomy, compromised by illness and disability, maximized such that they make an informed decision. So there's reason to have doubt. But if you look further, going back to Cabbage, if you look at the evidence, I've looked at about 30 charts when I was at the Cleveland Clinic, had them pulled from our warehouse where we store information, and just did this sort of as randomly. There is evidence of patient understanding and consent as documented in the chart. Now it's interesting, the Cleveland Clinic to this day does not use a standard informed consent forms. If law requires it, then they use a consent form. Obviously for research they do. Clinical consent, there's not standard consent forms. It's up to every physician to document consent as part of the medical record. And so if you look at typical Cleveland Clinic chart, you'll say discussed with patients, and it doesn't just say the risks and benefits and you leave it at that. You say discussed risks that surgery in particular patient was concerned about. We discussed this and blah, 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 blah. So you get those kinds of documentation. Now, I didn't see that level of the detail, but it was certainly the case that in the course of progress notes and looking at the nursing notes, there was evidence that there was not just between physician or surgeon and patient, but surgeon, patient, family, and nurses and others who were documenting in the medical record, there was an awareness of whether the patient was ready for surgery and ready to accept surgery, and or the family, and that sort of related to sort of how well they understand and accept the burdens and risks. So in a sense, I think there's some evidence that there may have been informed consent here, and I want to suggest that it may be no weaker evidence than we have in much of clinical practice to this day. Now, what about management of risk? Well, I think this is an interesting area because I think there's evidence for very strong but informal peer review in this case. The initial procedure was delayed by collegial skepticism, and risk was managed through careful patient selection. The overall surgical context was one of skepticism but openness to approaches. Now let me just give you read something to you here. I'm paraphrasing Rene Favillaro, who was the developer of this procedure. He says, initially this technique was used in patients in whom left ventricle had some perfusion via collaterals originating from the left coronary artery, because if the graft occluded, the patient would not be harmed. This was the initial use of the saphenous vein. He says, in discussions with Mason Sones, my Latin enthusiasm, Favillaro was Argentinian, was restrained by Sones, who was the chair of cardiology at the clinic. Many times he would say, look, what if the arteries in this particular case are plugged in 3 months? By the end of '68, we knew that veins would remain open without dilation within a year. So they gradually moved where there was collateral flow, where if the veins occluded or blocked, there was not going to be surgical harm to the patient, so they managed risk. So they tested the procedure in a way that tested it but did not pose the patient additional risk. They did that with a patch graft technique that actually excised and repaired the damage to the myocardium. And so in effect they got standard treatment, but a new, as it were, graft was done. Now, what lessons can we draw? And I'm going to start to summarize here. I think the ethical norms and procedures for innovative procedures should tend to reflect the state of art and the science at the time of the innovation. That is, if you're in a highly fluid field, we should be willing to tolerate a good deal of, as it were, experimentation and modification of standard procedures. Now, we now have worries about informed consent, but I think there are ways to manage that. I don't want to go into detail except in discussion, but the ways to manage that without saying we'll do formal research protocols, we'll rush it off the IRB, we'll get the stamp of approval, and then we'll go on our merry way and have our research nurses consenting people, because that doesn't give you the opportunity, as it were, to learn individually from each case. You say, but we got to do 5 more before we can do the next phase. But we're ready to do the next phase now, but we still got to do 5 more patients. Why? Because the IRB says we have to. And you hear this often in contexts where there's innovation. That poses, I think, some problems. I think we need to recognize that certain specific patient care problems, clinical exigencies, and opportunities are what drive innovation. I would suggest there's a distinction to be made between clinical exigencies and opportunities. Opportunities reflect where you say there's a marginal benefit to be brought if we modify, for example, a device or a procedure in a certain way. It'll make it more efficient, better. That's a little different than where, in fact, you have surgical problems that you have to, as it were, get inventive to solve these problems. And if you hang around surgeons for any period of time, and certainly I have, you find that the notion of a standard surgery is one that functions sort of within maybe a large domain, but at the margin, there's a whole range of cases in which surgeons are doing things that are a little different. They're adapting to dynamic surgical problems that occur in the care of the patient. And that's something that we need to recognize. And so why not encourage that sort of modification when, in fact, those things work? I think ethical assessment, rather than this prospective things, we do it once and we forget about it, ought to be concurrent. Now, we can talk in discussion that IRBs have a mechanism for allowing monitoring, but most IRBs, one, don't want to be bothered with it. There is a model for it, the Data Safety and Monitoring Board, but most of those don't provide the kind of monitoring that we would worry about in terms of the ethics. For example, you want to modify a procedure and you don't know if this is the appropriate case because you don't know the degree to which this patient and their family's values would accept those potentially unknown risks. So that's an ethical question that no DSMB is going to touch because they're just waiting for data to come in. No IRB is going to deal with because why? They meet the correct selection criteria. They meet the selection criteria. Yet these are clinical ethical problems that come up in the course of doing research all the time that, in fact, we don't have a way of dealing with. And I'm suggesting that if we rethought how we think about innovation, we might then come up with alternative mechanisms that would be different from the one-size-fits-all IRB. And I want to suggest that whatever mechanisms we do, they ought to accommodate the dynamic processes within which innovative treatments are developed and assessed, rather than we'll wait and we'll run everything through the randomized clinical trial. I'm going to take just a minute and tell you a little anecdote. We did a project, the chair of vascular surgery and I, with the FDA when I was at the Cleveland Clinic. We were looking at vascular surgery and some of the problems in designing trials, the issue of surrogate versus true clinical endpoints. And we got people from both the medical side and the device side, and there were some people from the biologic side in the room. It was rather interesting. At one point, the conversation broke down, and we had people shouting at each other. And it was people from the regulatory side for the medical, from the pharmaceutical side, shouting to the people regulating the devices and the biologics, saying, but the regulations really do require that we ideally should have randomized, placebo-controlled clinical trials with sufficient power and statistical power, okay? That's what the regulations really have in mind. And the device people are saying, no, 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 no. If you require us to do that, we'll freeze technology right now and we'll prevent technology from going forward. I mean, think about if, for example, we all decided we would test the utility of using word processors on the desktop. My first word processor on the desktop when I was at Southern Illinois University was tied to an IBM mainframe, and that's all the dang terminal did. Well, we would have tested that for a while, and we saw them effective, and we would have fixed that technology. Well, guess what? We got desktop machines later on. And guess what? They did a whole lot of other things. And some people got Macs, and we got graphic stuff. Technology sometimes moves faster than the ability to structure them within research protocols. So an important question from a device side is, when do we bring a device for trial? I'm not arguing we shouldn't subject things to clinical trial, but do we want to bring the first schematic device, the first generation, or do we want to let it mature enough? Because we can certainly kill a clinical approach to caring for patients if we assess it too early. And that's an issue that people tend to forget. Okay, this is a summary. On conventional view, new therapy should be carried out as for research. They're research subjects, no longer patients, and we got to protect them in special ways. The IRB and these formal research protocol are the best mechanisms for protecting subjects. And there are underlying this a lot of epistemological assumptions that I mentioned before, that innovations deviate from standard, accepted, and evidence-based practice, and that if they're legitimate, and this is important, it's only legitimate innovation that should be allowed in medical centers. And on this view, that's only able to happen if it's under an IRB. So you've got to have that stamp of approval, or else it's the cowboy surgeon. It's somebody on the edge who needs to be reined in. That's the attitude. Okay, so what would elements of an ethics of innovation involve? I think there's an ethical need for innovation. That is, the scientific nature of the clinical, of the patient care problems, clinical exigencies or opportunities for improvement. Those things need to, as it were, be the foundation. You need to make a case that this is necessary, this is justified, and I think we tend to omit that point, because we have a lot of things that come for clinical trial where, you know, you look at it and you say, as a member of an IRB, why are we doing this study? Oh, it's a junior faculty member. They need data lines on their CV. Oh, that's what we do? The mechanisms, whatever mechanisms for regulation, for oversight, must accommodate, I want to argue, the multiple points and types of innovation and the dynamic character, especially of early phase development of a procedure or device. I mean, if we're waiting and waiting and waiting and we think just bring it to my IRB meeting, put it on paper, you'll have certainly peers, but they won't know the subspecialty and they won't be closely related to the practice, and they won't, as it were, understand the details necessarily. You also need, I think, an institutional culture and system of support, and we tend to forget that some innovation occurs where we have a single innovator, but in fact, that innovator, a surgeon, for example, is going to work with surgical teams who are non-supportive of him or her. I mean, so you have real problems then in, for example, accounting for the quality of, for example, adherence to the protocol. Those are issues that I think we need to assess and build into the mechanisms for which we regulate. And finally, the quality of the innovators and support teams and the openness of communication. We do need peer review, but we need to remember that peer review isn't something that happens when the IRB reviews it. It's a peer review that occurs when I say to a colleague, have a look at this idea. Help me frame my protocol. When we engage in that, a lot of peer review occurs way before it goes to the IRB. But the conventional model tends to think that that's not legitimate peer review. It's only peer review if it's done by an IRB. And I think that's fundamentally problematic. And I'll end there. Thank you.
We now have time for questions. I know when we got to go to class, those of you who want to continue to. Questions? Yes, Professor Wiggins.
I wonder, George, if the arguments you made can't be more easily made for surgery, because there it is harder to run a large population in clinical trials. And if you look at other medical fields where it is easier to do research and standard far on a clinical trial, the argument for innovation, as you described here, isn't quite as strong.
Yeah, that's a very good point, Oz. Dr. Wiggins asked whether, and thank you for reminding me, David. Dr. Wiggins asked whether or not my claims are best suited and more apt for surgery rather than other innovations, for example, I presume in clinical medicine, in internal medicine, for example. I think not, because I think it's the case that if you look at, for example, alternate use of medications, you'll find that, for example, physicians were using what's the drug, minoxidil, right? Yeah, in Rogaine. Many endocrinologists were aware that it was growing hair. They saw that as a side effect, and some of them started to use it. It was the manufacturer that then said, well, we can market it. So it was a marketing interest. But it was being used clinically, in effect, because of that effect. And the clinical trials occurred because of the need for marketing, which was a regulatory issue for the FDA, not for any legitimate reason. Was it wrong for a clinician to use it? Now, I think we'd have to look at that. Gee, what were the risks and benefits? Because on first sight, somebody like me that's bald that says, hey, I've lived with this, why? What's the hubris involved that you need to sort of subject yourself to, a medication regimen in order, to grow hair? Well, for some people it matters a whole lot. And it may well be that if the risks are known and disclosed and reasonable, there was an evidence that endocrinologists could point to that say we've had an experience of the use of the medication that shows us that, in fact, the parameters of safety are highly acceptable. Now, later on, that got sort of vetted by more rigorous scientific standards, but I want to say a lot of that occurs in medicine, and we tend to overlook that and then tend to see innovation as something that comes forward not on the individual case, but only at the program level. It's only when somebody proposes to say, irrespective of what the manufacturer of the drug does by way of marketing, but where an internal medicine department says, or a division of endocrinology says, I can increase revenue if I set up a baldness clinic. Let's use minoxidil. Then we start to think about what's the evidence. But what's happening if it's used otherwise? And if you look closely at medicine, you'll see there's a lot of reports in the literature of these kind of off-label uses.
This is a quick yes, no, and then a follow-up. Are you saying that in an ethics of innovation there would not need to be some form of IRB oversight?
No, I'm not saying that at all. I'm just saying, and the question is whether in an ethics of innovation there would not need to be an IRB oversight. What I'm saying, or what I'm suggesting, is that the IRB mechanism is a one-size-fits-all. And, certainly it covers the thin man, but it's a very big suit.
And that was my follow-up.
Yeah.
Then would it be actually more prudential to consider having some form of a rolling N-of-1 trial type solution where you could try things, but there's a constant check and balance with the supervisory body as to whether this is truly best?
Yeah, and yeah, you're asking whether an N of 1 you could allow. I think the supervisory body, we have to be careful here because part of what we need to recognize is that the question you're posing is, what's the appropriate form of legitimation? The answer, only one we got, that's now been widely accepted as, given down from by the deity, the National Commission, wasn't that from Belmont Report? That was right next to Sinai, wasn't it? Anyway, was the IRB. That's the only way. When you look at bypass graft surgery, as an example, you find a lot of examples of forms of legitimation that were operating within, as it were, the practice. I mean, you have a highly communicative groups of surgeons who certainly are competing, but who are sharing information, who are willing to allow surgeons from another facility to come and watch procedures. We're at surgical society meetings. They're going and demonstrating procedures for others, even very early on where there's wide discussion. It wasn't the case as we tend to fear. Remember, we're influenced by certain paradigms we work with. The paradigm is the cowboy surgeon, right? Well, who's the cowboy surgeon? It's a renegade. It's like Sarah Palin, It's a rogue, somebody out there at the edge, someone you're not going to trust. They're not sort of part of the system. I mean, that's a model that certainly may exist, and I tend to think it does exist in small institutions. I saw some of that when I was at Southern Illinois University, where a surgeon was driving things through when there was opposition from everyone. It was only the medical staff that got involved in the credentialing committee of saying, no, we got to review what you want to do before you can even do it. And so what I want to suggest is that we need a better, as it were, sociological understanding of what mechanisms might work. It may well be the case that you build in, for example, into clinical patient care conferences an assessment of what's different. And I think where you have groups of physicians practicing with certain specific disease areas, it's much easier. Where you have that kind of, even if it's, and maybe most importantly, when it's interdisciplinary. We have surgeons and, for example, oncologists and surgeons working together. You end up with that kind of cross-fertilization and discussion. You have the radiologist coming in as well, saying, "Yeah, we got radiation treatments. Remember, got to think about that." That allows you then to sort of array all of the options in a fair enough way, and to select the patients that are the best for the particular innovation. So I'm asking, first of all, for a better assessment of what are the alternatives, and really questioning, do we really believe that there's only one mechanism for the review of research with human subjects, and that's the IRB mechanism? You may know, David, and some of the rest of you, I was on a Hastings Center panel. We did work on quality improvement. I think a lot of quality improvement now is run through IRBs in a disastrous way, and it's rather ridiculous because I think it's not formal research, and if you set up a protocol in advance, then you're at the IRB's door every day as you modify that protocol going on. It doesn't fit the model at all. So you need something more flexible and rolling, but that is a problem because institutions and IRBs are saying, but we got to protect the institution from liability. Yes?
Do you see a role for the doctrine, the legal doctrine of clinical innovation?
Yeah, I do, and I think that's been understressed in this context. And I think, we have to say, we need sort of much more reflection on that as a legal doctrine as it's emerged. I'm sorry. Thank you, David. The question was, do I see a role for the doctrine of clinical innovation? And I said yes. I think we need much more reflection on that because, as I understand it, that's a doctrine that emerged in the common law literature. And so I think we need to sort of look, what are the cases that drove it? What are the sort of limitations of the doctrine as it exists? Because it exists, as I understand, in different forms in a variety of jurisdictions because of the way case law is developed. We don't have, as it were, national standards for it. And so that's something to say, and what functions as a legitimate model of clinical innovation in one domain may be very different than another domain. That's why I spend a little time talking, and I hope you caught the point, that we tend to assume that medicine is stable. That's our standard assumption. And innovation is something just different, and it's problematic because it's different. I want to suggest if you look more closely at medicine, it's much more flexible and fluid. And if you understand that, then you begin to say, well, then what would be the appropriate standards for saying when are innovations legitimate and not legitimate? And those would be somewhat analogous to the appropriate standards that people are raising now to say, what are the appropriate standards for what we regard as standard practice? The whole evidence-based medicine movement, So I think that's a conversation in addition to the clinical innovation idea that we have to sort of bring in as well.
You, of course, George, know what the therapeutic misconception is.
Yeah.
It seems to me that the lines you're drawing here could even make that problem worse. And supposedly it's already bad in that people who are research subjects, in fact, think that these are standard therapy. So already it seems that there's widespread therapeutic misconception of research. And I'm wondering if we bring in this third category in their innovation, the problem can't be acted.
Well, as you know, can you hear me in the back? Can you hear me okay?
Yeah.
Dr. Wiggins asked about the therapeutic misconception. I think the answer is, as you well know, Oz is a phenomenologist. He knows that knowledge is structured by sort of a perspective, as it were. That is a perspective taken from the research context. We want you to understand this is research. Darn it. It's research. Darn it. Darn it. Darn it. We want that home. And then what's the answer to tell us that you do understand? It's a recitation of certain points of knowledge with respect to the study. Okay? But you're there. Again, in some instances, that's what you are. You were just going about living your life, and someone tapped you on the shoulder and says, would you come into my study? That's not the context I'm talking about. I'm talking about the context where I'm not feeling well, and I go to my doctor, and my doctor then says, oh, we have this clinical trial. I'm here to get care. Okay? So the therapeutic misunderstanding, misconception is structured as a problem because we want adherence to this scientific model, which wants to divest the epistemology, the understanding of the patient, from all of those things that they have as a patient. They've got to behave as a subject, after all. Quit being a patient, darn you. That's what we're doing, sociologically, in effect. And the fact of the matter is, we're all multiple things. We occupy many roles. Yes, you're a physician or a professor, but you're a father, you're a friend, you occupy all kinds of roles. We need to understand much more nuanced way how these kinds of commitments interact. And I think the way we've been thinking about innovation is as it were to funnel everything through the model of the IRB, which tends to have the following problems. It requires that you generate a protocol. And many IRBs won't and this is what's interesting to look at this from an IRB perspective, because the regulations don't really prohibit IRBs from taking, as it were, a surgical protocol, which have rather loose parameters, but many IRBs will say, no, that's not precise enough. I want to know exactly what the blood pressure range is. I want to know, before we as an IRB feel comfortable of approving that. Well, that's because they're working from the bench model of science, the model of science where you know in advance what the parameters are and you're controlling them. That's problematic. Clinical medicine accepts much more uncertainty. And I think we need models that are much more fluid. So it's the case of saying, we'll think about the ethics of medicine by saying to patients that you have a right to information and you can make end-of-life decisions. Well, guess what? It looks different when you're a patient than when you're there filling out your advanced directive or whatever. I used to talk to medical students, and after a number of years, some of them would fill out advanced directives, and I'd talk to them later on and say, now, let's see, I just exposed you to something, and your airway closes off, and you've got an advanced directive. You don't want, well, I really didn't mean that. No, because you were thinking, I'm 70 years of age, I've got multiple diseases, maybe a metastatic cancer, and now I'm going to spend the last 3 weeks of my life in an ICU. No, thank you. I don't want to be on a ventilator. No, maybe if I just open my airway and put me on ventilator support for 8 hours, yeah, I'll accept that. We've got to talk about that in a more nuanced way. The problem is people do these advanced directives, and then that's why we have an industry of clinical ethics now. You get the clinical ethicist in there to help interpret. What the heck does that mean? Sure, the patient checked it. And then you ask the family what was the circumstances under which they checked it. And they're much more complicated. Oh, the grandma was dying and she was under these circumstances. Yeah, but the guy's 30 years old. There's nothing wrong with him except he's got this infection and, every indication is he'll be fine. You're telling us he doesn't want to be on a ventilator? Did he really ever think about that? I think to say, but we're covered by the law if we don't put him on the ventilator and walk away is not acceptable ethically. And that's why these cases come for ethics consultation. Because, that rigid sort of, we'll do it in advance is fine if you're omniscient. None of us are. And so we can't control all the parameters. And I'm suggesting that when we think about innovation as something that's not just to test a scientific hypothesis, but really to solve a complex problem or set of problems, and it's a separate domain, then we realize really how complex it is. I'm suggesting positively that we ought to have some legitimation and oversight of that. And I'm in effect worried that the bioethics community is not thinking about that. Okay, it's too easy to say, oh, if it's not research, let the IRB do it. There's a bureaucratic answer. 3 doors to the right, that's where that office handles that problem. I find that unacceptable ethically. That's not very compelling to me. And that's the standard answer that you tend to get. I mean, after you parse through all the arguments, it sounds to me like somebody didn't think about the problem. They just said, oh, it's down the hall 3 doors to the right. That's what the sign says on the door. Yeah, it was an office 3 years ago, so now it's a broom closet. Nobody's checked, but they're sending you down there. I guess I'm one of these guys who went down and opened the door, and I said, it doesn't fit. And that's all I'm calling people's attention to. Let's have a much more creative and imaginative reflection on the problems of the ethics of medicine. And innovation poses a really interesting set of questions because it allows us not just to confine ourselves to what we tend to think of, face transplant, which you're real familiar with, and all, but a whole range. It's a very broad spectrum. And so we can see family resemblances, and we might learn what works in one context might work in another. That work hasn't gone on in the field, in my judgment. And I think the impediment to it is the unwillingness of people to get beyond this taken for granted set of assumptions, that's been cemented since 1974 in my view. And I certainly am the minority with this view. Maybe this is David's N of 1.
Then I thank you very much.
Thank you.